Mr. Chairman, ladies and gentlemen, I would like first of all to thank Jesse for his kind invitation and all of you to be here at this late time in the evening after having received so much information during the day. It's a great pleasure for me to have the audience like as it is. I am going to give an overview of what I believe are relevant facts that we have accumulated in the last years in several aspects of the delivery room management. Not all of them and not all of them in depth because there is no time for that. I will go through a brief introduction, then we will talk about achieving an effective respiration, then we will go into oxygenation. I will not speak about thermal stabilization and very briefly about cord clamping. Well, Elgan's morbidity, as Dr. Sol said, hasn't changed that much. If you look at this slide, and this was a study made by the neonatal network of the NIH, published in 2007, you see that most of the babies, especially the most small babies, are still lacking of a normal survival. They have a lot of morbidity, and they are affected by increased morbidity such as respiratory, nutritional, neurological, etc. So what the NIH-CDH stated is that the improvement in the survival of these very small babies would require determining, disseminating, and applying the best practices available, but also identifying new strategies and interventions. Because not all the knowledge is directly translated into the clinic. We published recently a paper of the Spanish Neonatal Society in which people, knowing what they had to do, they didn't do it because they didn't have enough experience. But we have also the necessity to search for new strategies and interventions. Well, the first minutes after birth, experimental studies in animal models have shown that interventions in the first minutes of life may be injurious and can cause acute but also long-term damage. And the hypothesis is that if we could do these interventions more gently and allow the baby to do a physiologic transition into the extrauterine world, perhaps we could be able to reduce the short and long-term outcomes. So immediate postnatal adaptation requires the establishment of an adequate gas exchange with an adequate ventilation, recruitment of the alveoli, and oxygenation of the arterial blood. But we have also to keep up with an adequate body temperature and a tissue perfusion. So how do we achieve an effective respiration? As you know, in the first minutes of life, the babies, the newborn babies, term babies, do very profound inspirations with high negative pressures of -40 or -50 centimeters of water, and they expand the lungs and they reabsorb the fluid that is in the lungs, and they establish what is called a functional residual capacity. For this, we need first to have surfactant in the alveoli, and second, to have active mechanisms of fluid reabsorption. However, in the preterm baby, this is not so easy because we have muscle weakness, so we cannot do a lung expansion with the same negative pressure. We have compliant chest wall, and we have elastic resistance. In addition to this, there is a limited synthesis of surfactant. So when we are doing inspiration and expiration, we are not reducing the alveolar tension surface. We are collapsing the alveoli in the expiratory phase and causing atelectasis in the expiratory phase. So when you are ventilating a term baby, what you see is that you go up into a high positive inspiratory pressure, around in the first breaths, as I told you, 30 to 40 centimeters of water. But when you expire, there is a residual pressure, what we call the positive end expiratory pressure of 4 to 6 centimeters approximately. However, the preterm baby doesn't have the strength to do such a positive pressure. He goes into 20s or 25s, no farther than that. But when he expires, he goes down into 1 or 2 or even 0 centimeters of water. So what we should try to achieve is to ventilate these babies with an adequate pressure, but try to keep at least 4 to 6 centimeters in the expiratory phase. If you have read the papers by the group of Melbourne, and Dr. Tipas and Stuart Hooper, etc., they have done a lot of studies in rabbits in which they have shown that if you give these newborn rabbits 4 to 5 or 6 centimeters of water at the end of the expiratory phase, you will achieve a functional residual capacity much easier, and then you will need less positive pressure in order to achieve an adequate gas exchange. In order to do that, you could do intubation and ventilation in every baby, or you could go into non-invasive ventilation. In the last years, we have been trying to be less aggressive with the newborn babies, and we have been trying to prove that non-invasive ventilation, being less aggressive, is as efficient or more even than intubation and ventilation. The CON trial was one of the first big studies that was performed in this regard, and it assessed babies from 25 to 28 plus 6 weeks of gestation that were already actively respirating. They evaluated the babies at 5 minutes, and if they were actively respirating, they were randomized to a non-invasive or invasive ventilation. So the numbers were 300 babies in each group, birth weights around 900 grams, and what they saw is that surfactant, by the percentage of babies that required surfactant by 5 days, was significantly higher in the babies that were intubated, and by 5 days also the number of babies that were intubated was much higher than babies that received CPAP. The days of ventilation was also higher in babies that were intubated as compared to those that received CPAP. In the COIN trial, however, they found that pneumothorax was increasingly higher, was significantly higher, in the group that received CPAP. And this is because these babies were spontaneously respirating, and they received a CPAP, an initial CPAP of 8 centimeters of water, which added a lot of pressure to these small lungs. However, in the rest of the parameters that they evaluated, there weren't any differences in death. There was a significantly higher number of babies that had need for oxygen at 28 days, but when you evaluated BPD as 36 weeks of postmenstrual gestation, there weren't any differences. So they concluded that this trial only recruited patients that were spontaneously breathing at 5 minutes, so they were good babies to be recruited. And the high CPAP pressure probably had some influence in the appearance, in the frequency, or in the appearance of pneumothorax in the CPAP group. The median ventilatory days was significantly lower in the group of CPAP. Another trial that was performed afterwards recruited babies that were smaller, 24 to 27 weeks, and they were randomized prior to delivery. So they chose babies that were in good shape and in bad shape, so spontaneously breathing and non-spontaneously breathing. In this sense, the trial was more revealing the reality than what you see in the delivery room. And the primary outcome was death and or BPD. They recruited a huge number of babies, 660 babies in each group, with very small gestational ages, and 70 to 75% of the babies received antenatal corticosteroids. As you see here, the differences were mainly in survival without mechanical ventilation, that was greater in this case, significantly smaller, in the intubation and surfactant group, and postnatal steroids, however, were more used in this group, in the group that received intubation and surfactant. What was commented about the support trial is that recruiting the infants before delivery included both good and bad postnatal adapted, and the results altogether considered were slightly in favor of CPAP. Well, in order to improve the effectiveness of non-invasive ventilation, some researchers have been studying the effect of sustained lung inflation. That means that in the first breaths that you give to the baby, you go up into the 20s, you keep this pressure for several seconds. It varies from one researcher to the other, but it goes from 5 to 15 or 20 seconds, in order not only to recruit the alveoli that easily open, but in order to recruit the alveoli that are atelectatic. So what you would see is in the left side of the panel is what you do usually. You ventilate the babies with positive pressure and then you go down in a few seconds. And you are always ventilating the areas where the air goes easily in. There is no resistance. However, if you maintain the pressure, what you see is that you first ventilate the easy parts of the lung, the dilated parts of the lung, but then you go into the ones that are atelectatic, and then you recruit them, so you increase the total number of alveoli that you recruit during your initial ventilation. What you get in the experiments that have been done is that you sustain the pressure for 30 seconds. If you sustain the pressure for 30 seconds, you are going to achieve significantly higher tidal volumes. While if you don't give sustained inflation or you do it only for 5 seconds, your tidal volumes remain similar. So what depends the efficacy? Why is the efficacy of sustained lung inflation? It will depend very much on the maturity of the lung, on the amount of fluid present, on the total cross-sectional area of the small distal airways. How long you prolong the sustained inflation, we don't know. It's not the same for a baby that's 24 weeks than for a baby that's 28. How much pressure you should put in the airways, we don't know. It should be it should be individualized. Perhaps in babies that are smaller, you don't need to put that much pressure, or perhaps you need more pressure. And the combination with sustained lung inflations plus PEEP is, at least in what is known up to date, the best approach in the experimental setting. This study, published in Pediatrics by the group of Leiden, by Dr. Tipas, aimed to give a sustained inflation early to achieve an early functional residual capacity, and they did it by a nasal prong, ventilating this baby for a time like between 15 and 25 seconds, and then afterwards giving normal ventilation. As you see the scheme, on the left, you would see how the average babies who were randomized to conventional mask CPAP were ventilated. First a higher PEEP and then lower, but the time was always the same. And the group that tried to achieve an early functional residual capacity got a very prolonged positive inspiratory pressure and then went into the conventional mode of ventilation. What they found is, independently of the gestational age, you needed less intubation in the delivery room when you used the prolonged and sustained inflation. And this was valid for not only for the delivery room, but also afterwards. They didn't find any differences in other parameters like surfactant dose or BPD, although the numbers were in the limit of being significant. And mortality was similar in both groups. They concluded that a sustained inflation plus early nasal continuous positive airway pressure through a nasopharyngeal tube is more efficient than intermittent manual bag and mask ventilation. Fewer infants were intubated in the delivery room, and fewer infants received more than one dose of surfactant, and fewer infants developed a moderate to severe BPD. And there was a reduced time of respiratory support. Dr. Lista also performed a study that was published in Neonatology in 2011, and they wanted to verify also about if sustained inflation applied at birth in preterm infants reduced the need for mechanical ventilation and improved respiratory outcome. They chose preterm infants below 30 weeks who received 25 centimeters of water for 15 seconds and compared it with a historical cohort. And they found significant differences in many of the parameters that I show you here: ensure, mechanical ventilation, exclusive nasal CPAP, surfactant, etc. This led this group of Dr. Lista to launch a multi-center trial in Italy, whose results are going to be published, I suppose, very briefly. And if you have any questions, he can answer you about the results. What he told me is that they didn't find really any differences in the big multi-center trial in most of these parameters that he had found before as significantly different. So the conclusions is that sustained inflations at birth in preterm infants with respiratory distress decrease the need for intubation, decrease the need for surfactant, shorten the time of mechanical ventilation, reduce the incidence of BPD, but do not reduce mortality, ROP, neurological morbidity, or neurodevelopmental outcome. So there are still a lot of questions that have to be answered. I already told you how much pressure. Are we going to put the same pressure in every baby? How long do you have to keep the pressure? How are you going to apply it, etc., etc. So we are looking forward to more studies that will answer these questions. This is the Italian study that I mentioned, but I think that we can discuss it afterwards. Regarding oxygenation, you know that immature babies have an immature antioxidant system, and that oxidative stress is associated with long-term and short-term damage. In transition, babies acquire normal oxygenation very smoothly, and the use of positive pressure enhances oxygenation, and we have to be careful about that, especially in sustained lung inflation, because you can go very easily into hyperoxia. This is our data from small for gestational age babies, in which we performed, these babies were not ventilated and didn't receive oxygen, and you see how babies around 2 to 3 minutes had a saturation of 55. When they got 5 minutes of age, they were around 75, and they needed almost around 8 to 10 minutes to reach a saturation of 85 to 90. If you were giving higher oxygen, like 90% as initial FiO2, you were getting oxidative stress, especially you were causing oxidation to proteins, and especially to certain lipids like arachidonic acid, and the isofurans were high, and also there was damage to DNA. And if you were going to give positive pressure ventilation initially, immediately after birth, you were going to get a higher saturation at the same time with the same type of babies as you were getting when you were not using a positive pressure. As you see here, these babies were on positive pressure CPAP initially, and these babies were spontaneously breathing. So in every minute, you had higher saturations when you were using positive pressure. So what initial FiO2 is best for Elgan neonates in the delivery room? So there was a recent publication in PLOS ONE by Brown and colleagues, and they randomized 6 studies. They studied 6 studies that were randomized or quasi-randomized that included a total of 484 babies, and they considered that initial FiO2 was low when it was below 50%, and it was high when it was above 50%. All these studies were, they were preterm babies below 32 weeks of gestation. The primary outcomes were mortality before hospital discharge and neurocognitive development at different stages. Excuse me. So The studies that were recruited or that were analyzed were the study by Harling, an initial study in 2005, the research through trial by Dr. Saugstad in 98, by Lundström in 95, our 2 trials with preterm babies, and the study that was performed in San Diego, and the study in Canada by Jacob Raby. What they found is that there weren't any differences independently of starting with higher or lower. There was only a slight tendency of reduced mortality in babies that were initially ventilated with lower FiO2. It was approximately at 20%, but it was not significant given the number of babies that were studied in this meta-analysis. We have performed with Dr. Saugstad as leader of this project a very thorough analysis. This hasn't been published yet, so I would appreciate if you don't take pictures. These studies are, most of them are recruiting very small babies, most of them are randomized, and all of them, are randomized, and many of them are blinded like our studies and the studies that were performed in Holland. Our results are similar to the results of the previous meta-analysis, although we have included different studies. And what we have found is that we confirm that there is a tendency, almost significant, to lower mortality in babies who initially received lower oxygen FiO2. And there isn't any difference regarding BPD or interventricular hemorrhage. So we conclude that meta-analysis of available randomized or quasi-randomized trial in preterm newborn infants less than 32 weeks indicate that the best initial approach should be an FiO2 of 21 to 30%. However, follow-up data are not available yet. This result is biased by the quasi-randomized trials, and there is no enough evidence to assess that secondary outcomes have been influenced by initial FiO2. Randomized control trials should be adequately powered, should be necessary, and the PRESOX trial is one of the trials that we are trying to launch in the coming months in order to prove if low versus high there is really a difference with an adequately powered study. Regarding delayed cord clamping, I would say that a 1 minute delay or until cessation of cord plus is warranted. Increasing placental transfusion may be achieved by positioning the infant below the placental level by oxytocin or milking the cord towards the baby. What are the advantages of delayed cord clamping? Well, it has been shown in a recent meta-analysis that in 2012, that it decreases the rate of death up to discharge, it decreases the need for transfusions for low blood pressure, the incidence of IVH in all grades, and it decreases also the incidence of NEC. Well, there is a new modality that has been studied in experimental setting in newborn lambs, in which the researchers have been ventilating the lambs while the cord was still being attached to the baby, so previous to cord clamping, and they have shown that you increase the blood flow to the lung and to the left myocardium, to the left ventricle, so you increase the capacity of adaptation, and you don't have this lower of the heart rate and the lower of oxygenation that we see usually when you do an early cord clamping. So perhaps in the future we are going to resuscitate or to help or to aid the transition of preterm babies, leaving the cord with blood flow and not clamping it until the baby is stabilized. They have shown it. Here you have, in this slide, excuse me, oh, I did something wrong. You see in this slide how they measured the carotid blood pressure and the arterial flow, and it was significantly increased when you left the flow in the umbilicus. They also got better oxygenation and better cardiac output. Final conclusions. I would say that delayed cord clamping is clearly advantageous for the preterm. Even during ventilation, that's a question that has still to be answered in the human being. Non-invasive ventilation appears to be preferable as initial choice to aid postnatal adaptation or transition in the delivery room. Whatever method in which you feel confident, the important thing is that the method that you use, you are confident with it, and you avoid the overdistension and you avoid leaking. It is essential to assure an end expiratory pressure of 5 to 6 centimeters to effectively achieve an adequate functional residual capacity. For this, you should avoid, as I told you, leaking of the mask or giving too much pressure, too much flow, and obstructing the airway. Sustained inflations apparently help expanding the lung and establish a functional residual capacity and diminish the need for intubation. And an initial FiO2 of 21 to 30% seems to be sufficient and has apparently short and long-term benefits as compared to higher FiO2. In this last point, I would like to underscore that in my experience, after many years of studying the oxygen supplementation, at the end of resuscitation, what is really important is the oxygen load that you have given to the baby, the amounts of pure oxygen per kilogram of body weight that this baby has received. This specific baby has a capacity of counteracting the deleterious effects of too much oxygen, and if you titrate adequately FiO2 and you keep it within an adequate range, you will probably cause less damage to the baby. Thank you very much for your attention.
Thank you very much, Max Vento. Now the paper is open for the discussion. Max, which is the role for the monitoring the positive pressure ventilation during the resuscitation in the delivery room? What is your experience?
Excuse me?
About the monitoring of the positive pressure ventilation.
Okay. Well, there is the next step that I think would be important, and this is the monitor trial that Dr. Tipas is launching and in which our hospital wants to participate. The idea would be the mainstay or the cornerstone of resuscitation is the achievement of a functional residual capacity, an adequate gas exchange, to recruit as much lung surface as you can, so you facilitate the gas exchange. If you do that, you will probably need much less oxygen, for one, so you will not go into hyperoxia. And probably you will require less pressure in the airway, so you will cause at the end less damage. Because we all know that from published papers, from published research, that even very experienced neonatologists in the delivery room, when they are ventilating, they are giving too much pressure because there is gas leaking from the mask, or they are giving too much oxygen because they believe they are ventilating adequately and the baby is not receiving enough oxygen because the saturation is not raising. And the problem is not of oxygen, the problem is of ventilation. So if we could have the means of controlling ventilation in the delivery room with a monitor that tells us that we are within a normal tidal volume, normal pressures, and we have the FiO2 and the FiO2 and the SpO2, we can perfectly and individually adjust our maneuvers in order to do the gentlest possible ventilation and resuscitation.
Thank you, Max.